Good afternoon, everyone. Welcome to the next episode of Pathagonia. So, continuing with our GI pathology theme, let's imagine that this is a stomach biopsy that you got from a patient with a gastric polyp. So, at low power, we can appreciate there's a lot of cystically dilated glands. Look like, areas like this look very cystically dilated. If we go in a little bit higher power and we go down in on some of these regions where these glands are a little bit closer together, we see closely packed tubular glands with a low cuboidal to columnar epithelium, and the cytoplasm is eosinophilic with somewhat of a ground glass appearance. And then we can appreciate that these nuclei are all basally located, and they don't really look overly dysplastic or like your typical adenoma that you would imagine, like a tubular adenoma that has that pencilate or elongated pseudostratified nuclei. These look a little bit more well behaved. So this entity is actually a pyloric gland adenoma, and a good one to keep on your differential. These can commonly occur in the background of autoimmune gastritis, and also can occur in patients with familial adenomatous polyposis or Lynch syndrome. And these pyloric gland adenomas, to me, they kind of have a almost basophilic or blue appearance at low power, which is something that can kind of get your mind thinking about a PGA or a pyloric gland adenoma. And you definitely want to take your time with this diagnosis, because they do commonly have dysplasia. They're commonly associated with dysplasia and even high-grade dysplasia at times. So I just finished up my GI rotation, and I rotated and worked with my mentor, Dr. Ramos, and this case is in honor of him.